Welcome to Chapter 8 of Exercise Programming for Special Populations. We're looking over neuromuscular conditions and disorders. All right, so your nervous system. You have your central nervous system and your peripheral nervous system. So central nervous system is your brain and spinal cord. Peripheral nervous system is that connects the brain to the rest of the body. Your peripheral nervous system is divided into a somatic system, which mediates volitional movement, the autonomic system, which is responsible for control of internal organs, things like such as your heart beating, your gastrointestinal systems, so on and so forth. So all the things that you don't have to necessarily think about to make it do. And then the other ones that have to do with the movements that you can, like me moving my arm up in front of my face just now, right? So neuromuscular disorders result in a decline in function of the body's nervous system or the muscular system. It can be classified as either progressive or non-progressive in nature. Progressive disorders involve continuing progressing deterioration of the function. Non-progression disorders do not get worse following the initial episode of disease or mechanical injury. So, say you're in a car wreck and you have some nerve damage in your arm, right? And keeps you from, like, if you're bending your fingers, you can bend all of them, but let's just say your index finger, right? So that may be a non-progressive where it doesn't ever get worse, but it doesn't ever get better, right? Progressive disorders would be things like you would see with like Parkinson's disease and so on and so forth, where the function that happens slowly gets worse and worse. Your tremors and things may get worse and worse. And so again, a lot of those can either be disease, or again, sometimes you could have severe damage that just, like not only can they not repair it, but that damage continues to cause more damage and so forth. So again, progressive disorders would be like MS, Parkinson's, muscular dystrophy, non-progressive cerebral palsy, stroke, head injury, or spinal cord injury. MS is a neurodegenerative autoimmune disease in which deterioration of the myelin layer, which we call demyelination, weakens electrical signals. Guillain-Barré syndrome, leukodystrophy, and Charcot-Marie tooth disease. That's one that I hadn't heard until I looked over the notes. Are other examples of neurodegenerative autoimmune diseases. Symptoms of MS are due to inconsistent or weak nerve transmission and include fatigue, numbness, walking problems, balance impairments, bladder dysfunction, bowel dysfunction, vision problems, vertigo, cognitive dysfunction, pain, spasticity, and depression. Lifespan with MS is similar to healthy individuals. There's different types. You have relapse remitting, which is 85% of cases. Individuals experience clearly defined exacerbations or flare-ups, followed by remission with symptoms stabilizing. Half of these will be considered secondary progressive after about 10 years. Primary progressive, which is 15% of cases, continual progression, it gets worse and there's no relapses. Causes are unknown, but there are several possibilities. Immunological T-cell active attack the myelin sheath, resulting in scarring of the nerves. Environmental incidence is higher when living farther from the equator, leading to speculation about lack of vitamin D being a cause. Saw a real interesting study that it's been years now, where they were actually looking at this, and they noticed areas like Phoenix, where people get a lot of sun, or Florida and areas like that. They're now, again, this is where they say it where living further from the equator leads to speculation, because even in those areas you can find people with MS. Now again, does that mean that maybe those people, you could probably survey them and see that maybe they live most of their life up in like Canada or so? I don't know. Or you may have some folks that grew up in, like sunny areas, and they still had it. So, they could have some other, issue, a virus or something that caused it. But anyways, they found that there seems to be less people with it in areas like Phoenix and Florida than in areas like in the Northwest, like, Seattle and up in Oregon area where there's a lot of cloud cover and people don't get necessarily near as much sun, or, areas like, um, New York where people may bundle up more for more months and so on and so forth. So, or even in the summer, they just, really don't get out and get a lot of sun. And they found these incidents of this. And so that's where this research is kind of leading to that speculation. So again, it's not necessarily confirmed, but it's interesting, right? And again, it's correlational. So again, correlation doesn't equal causation, but it creates an interest, where if you could figure out a pathological reason with the vitamin D, then that would be, that's where the correlational lead to more research that can either confirm or deny those type of allegations, so to speak, I guess. So infectious, I kind of hit on this. Viruses can also cause demyelination. Genetics, having relatives with MS increases chance of being affected. So again, it may be something that's passed down through traits. Again, maybe it's something that, you know, it's traits plus environment, and behavior, who knows, right? Um, Again, it's just one of those that, they they haven't quite confirmed exactly how all cases go, or all cases begin with each person. All right, so medications, disease modifying interferons reduce frequency of severity of the attacks, but have potential for reducing the capacity to exercise and capacity to recover between training sessions. Corticosteroids reduce inflammation. They can also reduce exercise capacity, and other medications to relieve a variety of symptoms with possible side effects. Participating in exercise will result in higher quality of life, but cannot slow the disease progression. So again, it helps them with their life, but doesn't necessarily have an impact on the MS itself. Um, Again, resistance training will improve strength, muscular endurance, fatigue, threshold, power, walking speed, balance, and quality of life. Participation in exercise will result in higher quality of life, but cannot slow the disease. Why is it doing that twice? um, Exercise recommendations, again, look at the table. People with MS may benefit from using seated resistance machines as opposed to upright free weight activities if their balance is bad. Non-weight bearing aerobic exercises such as recumbent cycling, aquatic exercise for one session per week at light to moderate intensity, 10 to 20 minutes per session, progress to 2 or 3 days per week, up to 30 to 40 minutes. Static stretching, again, is preferred to dynamic, and resistance training should be at least 15 rep max level for 1 to 3 sets, each of about 4 to 8 exercises. All right. Precautions: exercise only in cool temperatures and in well ventilated areas, maintaining proper hydration, prevent any increase in body temp. Discontinue exercise in the case of a flare up, restarting only when it's fully subsided, and be prepared to properly incorporate wheelchairs, canes, and walkers. And again, I've had friends and family that have this. So, I've had an aunt who's had this, and as a kid, it was really confusing because I didn't understand that sometimes she'd be walking around, seem fine. Sometimes she'd be having to use a walker, cane. Sometimes she'd be in a wheelchair. And again, she had, the where she would go into relapse and all that. And so it was just weird because, like she'd seem fine. Then, like, you know, next time I'd see her, she'd be in a wheelchair. Then, and again, we didn't live in the same city, so then I'd see her again while longer. She's walking but has a cane. So again, if you work with a client long enough, you may go through all that. And so again, you can't, you got to be prepared that, yeah, for a while you're working with them, they might be walking, running, doing all those things. You may have them where they need a cane or a walker, so you got to incorporate different type of exercise modalities. Then they may be in a wheelchair at some point, and they may go back, right? And so just understand that's a common thing when they go through their bouts. Parkinson's disease, second most common neurodegenerative disease, progressive brain disorder caused by death or impairment of neurons in substantia nigra region of the brain. Lack of dopamine normally produced by these cells causes the hallmark signs of Parkinson's, including tremors of the limbs, bradykinesia, slowness of movement, rigidity, and poor balance. Diagnosis of Parkinson's is difficult. There's no one test that can identify it. There are currently no medications to slow or stop the progression. Most Parkinson's symptoms are due to lack of dopamine. Most commonly prescribed medication is levodopa. Common side effects are nausea, loss of appetite, lightheadedness, confusion, hallucinations, reduced blood pressure, exercise capacity may be limited, or risk of injury becomes greater as the disease progresses. Cholinergic medications are used to reduce spasm activity, but carry increased risk of blurred vision, drowsiness, and confusion. COMTs, catecholmethyltransferase inhibitors, are used to prolong duration of activity in levodopa. And side effects include drowsiness and dyskinesia. Resistance training has been shown to increase muscle strength, mobility, walking capacity, endurance, balance, and increase fat-free mass in people with Parkinson's. Successful protocols include balance training, high intensity training, moderate volume, high load training, and high force eccentric training. Basically, it's tolerated by each person, right? Again, we've got full recommendations in the tables in 8. Recommendations follow those for older adults, as not enough research has been done to establish specific recommendations for this population. Resistance training, beginning with light to moderate resistance, focus on multi-joint exercises for 10 to 12 reps per set. One set sufficient at first, and progress to 2 to 3 as tolerated, with 1 to 2 minutes of rest in between. Balance training should be included to reduce risk of falls. Again, it's like we say with not only special pops, but we say with all pops, you just take your clients as they come in, you see what they can do, you see what they can't, just talk to them through everything. Like, you feeling all right during this? Do you feel unsteady? Do you feel drowsy? Do you feel sick? And especially these, like, when there's not a lot of research, particularly on a population, some people want to err on the side of let's not do anything because we don't know what may happen. But again, we know with movement and exercise and things like that, it tends to increase people's quality of life. And so again, we don't want to deny people a better quality of life because we're fearful of what may happen, right? So again, we've got these recommendations, but your client may be doing better than the average that have been studied. Your client may be doing worse than the average, and so just take them as they are. Just do your just constantly have dialogue with them. Just keep an eye on them. Anything you notice that's off is probably a good indication to either slow what you're doing or stop what you're doing, try something else. Or some days if things are just going bad, just, hey, let's give today a rest, we'll see you again tomorrow, those type of things. Again, with aerobic training, light to moderate, 30 to 60 or less than 60 of your VO2 or heart rate reserve, 55% to 75 max heart rate or RP of 9 to 13 on the RP scale, with 15 to 20 minute sessions per week to begin, and you can do progress up to 4 more 30-minute sessions per week as I can tolerate. Again, safety. Emphasize safety is like that with all your clients. Slower walking, less coordination, poor balance can increase risk. Treadmill walking is contraindicated, and overground walking or biking is preferable. Again, treadmills can be dangerous for folks, especially when you have neurological stuff, because any of you that have ever run on a treadmill, or it's a weird sensation when you get off of it. For one thing, because you get off a treadmill, you're running in place, and then as soon as you walk, say you get off the treadmill and you're walking over to get a drink of water, you feel like you're moving at an incredible rate of speed because you can actually walk. So again, when you have neuro stuff, a lot of times these stationary things, especially like walking, bikes, not so much, because you go from cycling on a bike to then, changing your mode of transportation, which would just be walking. It doesn't give you the weird sensation like doing the same mode of travel. Training at less busy times can avoid problems with adaptation to the environment. Consult with physician about timing of meds. Symptoms are more controlled just after medication has been taken. Monitor blood pressure to avoid orthostatic hypotension. Muscular dystrophy, group of progressive muscular disorders characterized by damage to muscle structure and progressive muscle weakening or weakness. Two most common are Duchenne and Becker. Both are caused by dysfunctional dystrophin muscle proteins. Individuals with the Duchenne have a complete lack of dystrophin, while those with Becker have dystrophin, but it only partially functions properly. So both Duchenne and Becker, or DMD and BMD, are inherited from the mother, and the chance of inheritance is 1 in 20,000 for Duchenne and 1 in 3,500 for Becker, and almost exclusively in boys. Early signs of the DMD are failure to keep up with peers in running, jumping, stair climbing, using arms to rise from the floor. This is called the Gower sign. Pseudo hypertrophy of calf muscles from scar tissue. Note that the same symptoms will develop for BMD, but later in life. Current lifespan for DMD is 30s. Boys with BMD survive into mid or late adulthood. With BMD, locomotion will become difficult. Wheelchairs necessary with disease progression and cognitive impairments are common. Myotonic MD, the most common adult form of muscular dystrophy, is myotonic. It affects women and men equally, is inherited, occurs in 1 in 8,000 live births, and seen in people between 20 and 30 years old. People with myotonic MD are unable to relax their muscles, have highest rate of cognitive impairment, slow disease progression, contractures, breathing, swallowing problems, cataracts, heart problems, and insulin resistance. 6 other types of muscular dystrophy are congenital. You have Emery-Dreifuss, facioscapulohumeral, limb-girdle, distal oculopharyngeal. Corticosteroids are administered to treat symptoms and slow the progression, but they have side effects that include depression, anxiety, high glucose levels. Heart meds such as ACE inhibitors, beta blockers are commonly used to treat heart conditions. Side effects may include dizziness, low blood pressure, and weakness. Traditional resistance training is generally not recommended for individuals with Duchenne or Becker, but some submax isokinetic training can increase strength. Aerobic exercise causes fatigue but does not appear to impact normal activity the following day. Submax cycling, about 65% VO2, can improve their VO2 max over a 12-week training period with no adverse effects. In adults with MMD, 12-week high-intense resistance training program shows improvements in 1 rep max strength with no adverse effects. Aerobic exercise should be low impact, perform 1 day a week, progress 2 to 3, light to moderate, 55% to less than 75% max heart rate. RP 9 to 13 sessions should be 15-20 minutes and progress to 30. Resistance training should be isokinetic with concentric movements only. Using light intensity, begin with 1 day per week at a low intensity. Volume can be increased slowly as tolerated. Prevent maximal exertion and be responsive to reports of fatigue or pain. Stretching should be performed very slowly and held for 60 seconds. And eccentric activity should be avoided. Cerebral palsy, a group of non-progressive permanent neurological disorders that are caused by a variety of birth injuries. Disorders affect CNS and are primarily characterized by limitations in motor control. They affect body movement and posture. Spasticity, hypertonia are common symptoms resulting in gait abnormalities such as crouch gait, scissoring gait, toe walking. These are other motor impairments, can have other large range of severity. If you've ever seen anybody with cerebral palsy or know anybody, I used to have a friend when I was a kid, had it. He used to have those crutches that would grip on the forearm, and he had the toe walking. So he'd use the crutches and go side to side, and it always looked like his calves were, like his calves were in flexion, or he was doing like plantar flexion with his feet, so his calves were always like tensed up, or like muscle flexion in that area. I remember when we were growing up. So again, it's it's hard. I can't imagine going through that. Three main forms of cerebral palsy are spastic, ataxic, and athetoid dyskinetic. Spastic makes up 75% of cases and is a result of damage that interferes with the uptake of gamma aminobutyric acid. You'll just see it listed as GABA. Primary inhibitory neurotransmitter. Ataxic cerebral palsy affects the cerebellum, makes up 10% of all cases. Limitations in coordination usually make tasks like writing and upright balance difficult. And athetoid cerebral palsy is characterized by a mixed muscle tone that limits the ability to hold upright sitting or walking postures. It's caused by complications affecting brain development that arise during pregnancy, childbirth, or infancy to 3 years old. Cause could be an infection such as rubella or toxoplasmosis. Rh factor incompatibility with the mother or some other unknown cause. During childbirth, oxygen deprivation or head trauma may be the cause of cerebral palsy as well. Seizures are likely secondary symptoms, so anti-seizure meds are common. They can limit exercise capacity, produce mental confusion, irritability, dizziness. Antispasmodics relax muscle, but may induce lethargy or drowsiness as well. Physical work capacity for individuals with CP is less than half that of their age-matched peers, indicating a need for exercise. Both aerobic and resistance training programs have been shown to have positive effects in VO2 peak muscle strength, resulting in improvements in gait capabilities. There's recommendations in 8.4. Variations of functionality, specific recommendations are not going to be well established. Again, they'll say, start about 30 to less than 60% of VO2 or heart rate, 15, 20 minutes. I mean, basically same things we're saying. Again, you just got to take them where they're at. And just, also, one of the hard things you got to learn to understand too, the longer that you work in our field, is some people are going to tell you like things are hard when they don't want to do stuff. And sometimes people are going to tell you things are hard when they really are hard for them to do. So like at first with everybody, I just take them as they are. If somebody's telling me like, hey, I can't do that, or I don't think I can go another minute, I just trust it. After you've worked with somebody long enough, you can tell when they're like trying to get out of something and they're not. Again, when you have special pops, trust them more often than distrust. And just because you may, again, you may get used to like when they're like, they're just a little tired, or versus like there may be an issue. But again, with things, like especially when you're trying new things, you never know how it's going to affect. So with that in mind, just always err more on caution with populations like that, like cerebral palsy and all that, because you never know, especially like with the MS, just because things come and go. So just because everything's been good for the last week doesn't mean start Monday the next week they may not start progressing again, right? Again, resistance training recommendations have two exceptions. Free weights may not be appropriate given limitations in balance. Intensity must be calibrated based on capability. Again, you could do free weights. You know, like if you wanted them to do like say bicep curls with like dumbbells. You know, if you're worried about risk of falling, there's like you can get some grip things that like you can kind of tie them. Like used to fasten their hands to things. There's different things you can do. Just again, make sure it's safe for them. And definitely, keep an eye on them during every exercise, every second of every exercise. Don't take your eyes off. Again, arm exercises may be appropriate for some individuals, and modifications of equipment such as using straps for bike pedals may be necessary. Muscles under spasm activity should never be forced against the spasm. TBIs, acquired injury to the brain that takes place when sudden traumatic force causes damage to the brain tissue. Traumatic brain injuries can be classified based on severity ranging from mild to moderate and severe. Brain injuries are usually graded in the emergency room based on whether the injury caused unconsciousness, how long the unconsciousness, individual's verbal, motor, eye-opening response to stimuli. Mild TBIs, including concussions, either do not result in loss of consciousness or the individual is unconscious for 30 minutes or less. Symptoms may appear immediately or in several weeks. Moderate TBIs result in loss of consciousness for more than 20 minutes, but fewer than 6 hours. Physical, cognitive, behavioral performance may be impaired for months and potentially for life. Severe TBIs are generally a result of traumatic head wounds, both closed head and penetrating injuries to the head, resulting in unconsciousness lasting more than 6 hours. These more severe injuries result in significant damage to the brain tissue with a range of behavioral, physical, and many different aspects of daily life. Most common TBIs are falls, motor vehicle accidents, struck by object, and assaults. Impact causes initial damage, but altered blood flow or inflammation can cause secondary damage, and secondary damage is more responsive to therapeutic interventions. There's no medication to treat actual brain injury. They can treat associated symptoms using pain meds, anticoagulants, antispasticity drugs, anticonvulsants, side effects of opioid analgesics, including nausea, drowsiness, urinary retention, orthostatic hypotension, which can limit exercise capacity. Anticoagulants such as warfarin carry risk of increased bleeding. Anticonvulsants or anti-seizure meds have side effects including fatigue, digestive disorders, dizziness, blurred vision. Aerobic training is safe and effective, improves peak power outputs, increased VO2, reduces depression. Aerobic exercise can be as effective as it is for individuals without TBI, and there's currently no evidence in support or against resistance training on individuals with TBI. So exercise recommendation, no specific recommendations. But recommendations for older individuals can be used with modifications. Again, basically what this whole slide, before I go into, again, take them as an individual, see what they can do, what they can't do. Just kind of follow their lead a little bit, challenge them without like over challenging them. Again, make sure they have medical clearance and modify any exercise that you think would help them. Again, if they have motor deficits or balance impairments, just be aware of that and work around that. Try your best to maybe help them with getting better balance and trying to close some of those deficits. Sometimes you may see some improvements, sometimes you won't. One of the things I'll tell you before we get off on the TBI, there's been some research on creatine levels in the brain with like as preventative strategies with TBI that shows some promise. Again, it's right now it's not enough research out there, and I'm sure there's some research going on with post TBI and increasing creatine, just because we know that creatine has a lot of good cognitive benefits. And again, we know that creatine levels in healthy brains tend to be higher than those in unhealthy brains. And so just reason I bring that up is being that, you know, we deal with supplements, and especially creatine is one of the main supplements that we look at in our field. Be really interesting to see some of the things coming out of some of these studies with creatine and traumatic brain injuries, either pre or post, and what the effects are. And hopefully we'll see some positive effects with it, as we do with most everything creatine does. So strokes, serious vascular event in which there's a loss in neurological functions of the brain related to acute interruption of blood flow to the brain. Again, there's ischemic, which is 80% of cases which blood flow is interrupted by physical blockage, or hemorrhagic, which is 10 to 15 of cases which occurs as a result of bleeding in the brain. Other forms of stroke in transit is transient ischemic, TIA, also known as a mini stroke. Nutrients for the brain function are not stored in appreciable amounts in the tissue. The amount of time that blood flow is blocked is going to be crucial. A stroke on one side of the brain produces deficits on the opposite side of the body. Paralysis on one side of the body is referred to as hemiplegia. A variety of factors, some controllable, some not, increased risk of stroke, including smoking, high blood pressure, inactivity, obesity, age, heredity, and race. So again, nothing you can do about heredity and race. Again, they place you at a higher risk, but usually you know, with that, you can look at, like, you know, that's a small piece of the pie, but all those other things that we just spoke about that you can control, um, you know, you can't control, you know, like heredity, your race, you know, again, some of these things you'll see are more prevalent in men, or some things are more prevalent in women. Can't control any of that. But again, that doesn't mean that if you're born a man, born a woman, you're born a certain race, or born certain race, that you're, you know, and you've seen it in your family, doesn't mean you're absolutely going to get it either. What we do tend to notice is people with poor behavioral choices tend to have a much higher risk. So control what you can control, right? You know, and that's kind of the moral of the story with this stuff. You control what you can control. Like, don't partake in lazy or risky behaviors in those regards. Ischemic stroke are caused by either thrombosis, embolisms, or global ischemia. Thrombosis is blockage of a brain blood vessel, usually from buildup of fat and cholesterol in the blood vessel lining. Embolus is a clot that travels to and lodges in the brain. Global ischemia occurs because of whole body ischemia from the heart attack or others, such as catastrophic loss of blood pressure. Hemorrhagic strokes are caused by rupture of a blood vessel because of damage to the vascular structure, such as cerebral aneurysms or chronic high blood pressure. Aneurysms are an area ballooning on a blood vessel due to weakening of the vessel walls, which may rupture and cause bleeding into the brain. Medications, again, blood thinners, including antiplatelet drugs, anticoagulants, are administered to reduce chance of additional clot formation. They increase chance of bleeding complications and may be a reason to avoid vigorous physical activity. Blood pressure medications, again, like angiotensin II receptor blockers, ACE inhibitors, beta blockers, calcium channel blockers, diuretics are commonly prescribed. Side effects, again, include dizziness, drowsiness, tiredness, fatigue, and stroke victims may also have various comorbidities that need to be addressed. As you see, the behavior that leads to heart issues and lung issues and type 2 diabetes is also the same behaviors that leads to stroke. Therefore, somebody that's had a stroke or at risk for a stroke may be at risk or had any of those other things, or has any of those other things as well. Exercise intolerance as a result of stroke and after effects of stroke can cause deconditioning, gait inefficiency. Clinical exercise programming will seek to improve motor deficits, increase the ability to carry out activities of daily living. Most recovery will take place within 9 months. Aerobic training improves aerobic capacity similar to those without stroke and reduces energy costs at submax effort walking. Implies improved gait efficiency. Use of treadmill with handrails or harness is used to control loading and intensity of exercise during recovery. Resistance training improves strength, power, muscular endurance, neurological activity. If you go to rehab settings, they got some really cool treadmills where they'll put you in harnesses. Some of them they'll have like a crane apparatus above you that you'll be where it'll deload. So like if you weigh 200 pounds, you can deload it by 10 pounds or 20 pounds or whatever you want. You'll see some of them where they have them walking on treadmills where they get into a harness, and their body's submerged in water and the actual treadmill's in the water. So again, they use the water as a buoyancy to deload as well. So yeah, there's some neat tools that they'll use in some of those rehab settings. Again, aerobic training can use legs, arms, or both at intensity of 40 to less than 60% of VO2. Heart rate reserve beginning with 1 day per week, progressing 2 to 3 days a week. Sessions should last 15 to 20 minutes at first, trying to get to 30. Resistance training should be similar to programming for the elderly. Unilateral movements involving the affected limbs should be used. Again, the more they move, again with the stroke and inactivity as a result of, some of the problems there is due to the brain damage. Some of the problems that they're going to have, especially months afterwards, is going to be maybe due to inactivity of using that area. So if the area can move and they can do some work, have them do some work, stretch them out, do all those things, because there may be improvement. Again, it may not, depending on the severity of the stroke, they may not ever be like completely bilateral equal, but that's not the most important thing. If they can, like if they have very limited function, say on the right side of their body or the left side of their body, and you can do work with them and you can improve that function, well, that's always a positive, right? Equipment selection should be guided by motor limitations, may include the use of recumbent bikes, steppers, and reciprocal push-pull devices. Grip strength can be enhanced using specialized mitts. Again, if they have issues with gripping something, but they could actually do the movement, if they could actually hold on, again, there's all kinds of specialized tools that you can use to fasten their hands to things. Again, the grip strength, and again, I'm not saying not to work on the grip strength, but again, you've got to look at when you want to work on grip strength. So say again, if I'm trying to work on shoulder push-pull movement, and I need them to hold on to something. Well, if the goal of that exercise is shoulder push-pull, but they can't grip, then I'm not going to worry about grip strength on that exercise. Now, again, I can work on grip strength on other exercises, so again, sometimes we get in this thinking, and again, you see this, not just with these populations, but general populations where people are like, oh yeah, you got to always do multi-planar movements, like you got to do, like a squat to press if you're going to do like your shoulders and say, like it's like always like multi-joint movements. And again, I've got nothing against multi-joint movements. I love multi-joint movements, but understand what you're trying to do in something. So if I'm trying to strengthen, push pull in the shoulder, like either horizontal or vertical, then I'm not going to limit their ability to do that by requiring them to do a, like work on grip strength while doing it. If it's not conducive to, like increasing their strength here. So, if they can only grip something and pull with it up to 10 pounds, but they actually have the shoulder strength to like push something like at 50 or pull something at 50, why would I want to limit that progression by trying to do the grip strength where I could isolate the grip strength on something else while we just work on the push pull? Does that make sense? Sometimes we get so much into this, like, do all the major muscle groups, do them all together, and again, from a performance standpoint, working with athletes, for the most part, that's fine. But even with athletes, we do some auxiliary lifts where we can isolate, the elbow or isolate the, shoulder in a movement or isolate the knee, and it's beneficial. So I don't know why some people get so stuck on that. Again, use of resistance training machines with good torso support, chest straps may be necessary. If progress dictates, chest straps can be gradually removed. Spinal cord injuries is an injury or disease process of the spinal cord that results in altered motor, sensory, or autonomic functioning. Injuries of the cervical region affect the upper and lower extremities, as well as trunk, producing a state of tetraplegia. Injury to the thoracic or lumbar vertebrae levels produce paraplegia or deficit in lower extremities, some portions of the trunk, and designation of injury is further described as vertebral level of the SCI and the completeness of the functional deficit. Again, spinal cord injuries are never the same because where it happens, right? So the higher up it happens, the more areas of the body tend to be affected. Spinal cord is protected by vertebral columns, but injury can occur even with the vertebrae intact, vertebrae intact. An injury can be transection, where the cord is completely cut, or contusion, which is a bruise on the cord. Further damage after initial injury can occur due to swelling. Most common cause of spinal cord is motor vehicle accidents, 39% of injuries, while sport activities result in 8%. Again, every mom warns you. I don't, well, I'm not gonna say every mom, but most of the moms, including mine, when you're a young man and you want to play football, that's the one, you're gonna break your neck and you're gonna be a paraplegic or quadriplegic, and again, it's a possibility, but it's an 8%. To me, that's a very low percentage. And again, if you do everything right by the book, you're going to reduce your personal chances with that. Again, medications are typically prescribed to treat symptoms, so like NSAIDs for joint pain, and there's no pharmaceutical method to reverse spinal cord injuries. Tricyclic drugs, select serotonin, norepinephrine reuptake inhibitors to treat neurogenic pain. Side effects can be nausea, drowsiness, sedation, lightheadedness, dizziness, muscle weakness, which can all significantly reduce ability for them to do exercise, especially at vigorous, or to maintain their balance as well. Itrapan for bladder control, depression, autonomic dysreflexia can produce dizziness, weakness, and drowsiness. Prozac, Zoloft, Wellbutrin, antidepressants that will produce dizziness, fatigue, and nausea. Note that if an episode of autonomic dysreflexia, large increase in heart rate and blood pressure, occurs while a person with spinal cord injury is on meds, medical assistance should be sought immediately. Functional capacity is limited due to motor deficits, less available muscle. Severity of the spinal cord injury will determine the extent of the limitation. Autonomic dysfunctions will also limit capacity due to cardiovascular limitations and is present with complete spinal cord injuries above the T4 level. In addition, venous return from paralyzed limbs will be impaired, requiring a higher level of oxygen extraction, leading to earlier local muscle fatigue. Increase in VO2 peak have been demonstrated while moderate intense arm crank ergometry work. High intense upper body resistance training paired with low intense arm cranking has been shown to improve strength significantly as well. Aerobic training should consist 1 to 3 sessions a week, 15, 30 minutes per session. As tolerated, intensity should begin 30 to less than 60. Or an RP of 9 to 13. Training modes will usually be limited to arm crank exercise or reciprocal press pull exercises. So you could think of like rowing and things like that as well. Resistance training should be done once a week. At first, using one set as a light intense, 40-60 of 1 rep max. Progressing to 2 to 3 days per week at high intense, using multiple sets with 1 to 2 minutes of rest. Exercise professionals should be familiar with the level of injury and assign exercises as appropriate. Be careful not to overload the available musculature, especially muscles that are used repetitively for wheelchair transfers. Exercises should use antagonist muscles to those used in daily movements, and torso stabilization may be difficult or impossible for some individuals. Therefore, you may have to stabilize them. There's things where, like they've got straps where you can strap them to a bench and so on and so forth, or chairs, or you can, or stabilize them to their chair, and you can have their wheelchair pull up to a lot of different machines as well. And again, wrist straps may be needed if they have grip weakness, so on and so forth. So again, this shows areas of tetraplegia to paraplegia. Again, the higher up, the worse it is. All right. Epilepsy is a collection of disorders characterized by recurring seizure activity caused by an excessive electrical discharge in the brain that disrupts normal patterns of brain electrical activity. So you will get diagnosed with epilepsy if you have at least 2 unprovoked seizures, more than 24 hours apart. One unprovoked or reflex seizure and probability of further seizure similar to general reoccurrence risk at least 60%. After 2 unprovoked seizures occurring over the next 10 years, diagnosis of diagnosis of an epilepsy syndrome. All mean that you'd have it, right? Seizures can have a variety of outcomes ranging from blank staring, jerky movements to convulsions that lead to unconsciousness depending on the area and amount of the brain affected. Duration of seizure ranges from seconds to minutes, often with disorientation after seizure ends. And they're classified as either primary, generalized, or partial focal. They can be brought on by eating certain foods, changes in hormone levels, stress, sleep patterns, photosensitivity. Sufferers are encouraged to take their medications regularly. Causes unknown, but could be head injury, brain damage during or before birth, brain tumors, genetic lead poisoning, infections such as meningitis or encephalitis. Determining the source, if possible, is important to determine the proper treatment. Anti-seizure, anti-epileptic meds are the most common and can control seizures in a large majority of people. Side effects include fatigue, dizziness, blurred vision, behavioral changes, depression, weight loss from exercise may necessitate a change in dosage, but a physician's got to be consulted. Again, individuals should not deviate from their dosage pattern, regardless of the side effects. Again, if they feel like something bad's going on because they're starting to lose weight and it has to do with the meds, they need to talk to their doc. You're not going to tell them like, oh, well, you weigh less now, so you might not need as much. That's not for you to determine, right? You're veering out of your lane. People with epilepsy have lower resting metabolic rates and resting oxygen consumption, but decreased EEG activity. Following exercise. Exercise does not decrease the rate of seizures, but does improve VO2 peak, strength, body comp, and quality of life. Primary concern in a seizure is a seizure during or immediately after exercise, but exercise-induced seizures are rare. Exercise prescription is similar to that of deconditioned adults. Again, it's one of those things that like you got to think of it this way, and this isn't like a perfect explanation, but like some people like really bright flashing lights such as strobes and stuff can initiate a seizure in certain people. So you got to think of exercise sometimes, like that's a very harsh photosensitivity that can do something. Same thing with any, like if you have somebody jump into certain exercises, it can be, again, kind of a shock to their system, which could lead to that. So again, if you think of it as easing them into things as you would a deconditioned, a deconditioned client, there's less chance that you would have a seizure during or after, right? Again, be familiar with first aid procedures for seizures. Allow the seizure to proceed. Do not place anything in the person's mouth. That used to be an old school thing where they tell you to like try to place something in their mouth so they don't swallow their tongue. But do protect their head from injury. So, if they're having a seizure and they're near something where they could bang their head against something, either sharp or hard, like protect them from that. Call EMS if the person has difficulty breathing, has seizure for more than 5 minutes, or multiple seizures without regaining consciousness, or if the person is pregnant, injured, or diabetic. If there are frequent seizures, avoid exercises that might result in injury if the seizure occurs, including certain weightlifting activities, treadmill activities, and water activities. Again, this is one of those chapters that it's like you probably have more questions than answers. But it's one of those chapters that kind of is going to wake you up to the reality that really in our field, you're going to have individuals that, and again, whether they're somewhat healthy or if they are in special pops, that you're always going to have to tailor programs. You're going to, there's not, like I said, we don't have a recipe or remedy that really works for everybody. We have some basic recipes that will always have a lot of tinkering based on who you're working with. So, and that's just the reality of what we do. All right. See you guys in chapter 9.